Good morning, everyone. I know there's still a few of you trickling in this morning. I'm Kimberly Chalia with PHCA. Thank you so much for joining us for today's webinar, Nursing Economic Crisis Before Staffing Mandates with John Henson. A few quick updates to share before we get started. This webinar is being recorded and will be made available on the PHCA website. The webinar has been approved for 1 continuing education credit for all attendees. For those who provided a NAB number, credits will be uploaded shortly, and we'll also share certificates with those in attendance. As we begin today, all attendees will be in listen-only mode. Please feel free to submit your questions via the Q&A icon on your screen, and make sure to answer as many of those questions as possible at the end of today's presentation. Now I'll turn it over to John.
Okay, thank you, Kimberly. I appreciate it. So today we have an hour together. The presentation portion, 50 minutes, save 10 minutes in for Q&A. If questions come up that are pressing, you'll feel free to ask, and Kimberly, please feel free to interject and ask, otherwise we'll answer them at the end. This presentation, this is the first time I focused on Pennsylvania for it. I've given this presentation for other Mid-Atlantic states, and really the challenge, as I perceive it, is it's kind of negative, and I'm trying to find opportunities and for positive and ways care can be structured, and so I'll speak to that. Okay, so I'm just going to hit that off, and I'm going to try to speak to positives and opportunities, and really just to say things how they are and how strategies or planning in the future, right? So we'll speak to that. The presentation is more finance, accountant focus, and it's even for me an accountant hard to say. So when I notice that, then I know it is pretty finance accountant focused. So I'll try to delve into areas too. So if you have questions about what in the world I'm talking about in some areas or some calculations or what went into some calculations, feel free to ask. I want it to be understood. I think this topic is very important. And I know that PHCA and ACA nationally are advocates for what's going on with staffing mandates. They're advocating very strongly on providers' behalf. And so I know that's happening, but also just for me working within healthcare, and I'll speak to my background in a second, I know this topic is very important, and I see it happening right now. So I'm out of the Baltimore office for CLA. I service senior living and health systems, for-profit, nonprofit, and really all over the levels of acuity, from the life plan communities to nurse facilities to those that are pure AL, for-profits with a separate operating and real estate companies, or real co-opcos that do that as well, and then have some health system clients and also mental health and inpatient behavioral health. So all over the charts, it's all over the spectrum of levels of acuity is what I see. And I see I do audit and some consulting affiliation work too, but my point of saying that is that from what I've seen, it's been painful. It's been tough. It's the federal grants monies have dried up, and now we're in a position where folks are looking at more grant opportunities that are out there. And so this is a poll. I don't think for our time together a webinar, it's tough to do a poll in live, so I'm not going to go through that. But the overall gist is that nursing has been hit hard, right? I mean, this isn't news to y'all that are operating and are in finance that see the numbers. It's workforce costs. It's that when the directives and mandates came down from the state and local level on providing enough care, that affect occupancy, right? You have quarantine decisions, you lower occupancy. There are directives and mandates over visitation and how the nurses, direct care providers operated with residents, right? So that could affect occupancy. Right, more older adults were taking care of their parents with home health or home care, and only admitting them to nursing and assisted living when they really had to. That was a trend for a while. We've seen some trends come back for sure, of where it's just after COVID hit, their parents need nursing care, right, and they can't take care of them at home any longer, right? So they're admitting back to nursing. So we've seen some stabilization. I have data in this presentation about where things are most recently in occupancy for Pennsylvania. So. But even if you could get occupancy up to 100% or 95%, that's still not necessarily going to make money, right? I mean, it's like nonprofit or for-profit, it's no profit these days. And some providers are looking out, 2 years to get to a break-even point from an operating margin perspective, even before considering debt or leases or whatever, have you structure the real estate. So it's tough, right? And then you got from a state level in Pennsylvania, and then at the federal level, the White House has talked about a national mandate for staffing, and then Pennsylvania is raising their minimum staffing levels. And at some point, it's like, well, you can make it whatever you want. I mean, you can't even hire great staff. That the staff that you need to take care of your residents, you can't even hire them if you wanted to. So at some point, it gets kind of nonsensical. But this data is going to go through. The presentation has numbers in it for the cost. And I try to break it down by regions and per facility, and then the staffing necessary. White House has set a goal of March 2023 for enacting a mandate, and I'll try to speak to, when I say mandate, what that means later on. And then also I just took some, so I looked around Pennsylvania and the Mid-Atlantic. I operate in Mid-Atlantic. I work with clients in New York through Virginia for the most part. And I took some of those mandates that already exist out there, right? So New York, if you took New York's existing mandate, which is 3.5 hours per resident day, and I'll get into the accounting for that later, the calculation, but if you took that mandate and just layered it over current Pennsylvania providers, 52% would be below the New York's mandate, staffing mandate, right? So it wouldn't meet that regulatory requirement. If you took DC's, which DC is one of the highest in the country, 4.1 hours per resident day, and applied that to Pennsylvania, 74% would be below regulatory requirements, right? And then our federal government, based in DC, is now looking at adding staffing mandates. So I'll go through some scenarios as well, what that looks like. But I mean, you don't even have to be an accountant to realize that it'll take more costs and or staffing to meet mandates. And then also this, this probably isn't news to the operators out there, but the major piece missing for meeting these mandates is the aides, nursing aides, certified nursing aide position. That's the biggest gap. There's some below for RNs and LPNs, but it's the nursing aides that are the biggest need out there, which isn't news to operators. So I'll go through the presentations divvied up into the industry before even talking about staffing mandates. What does Pennsylvania look like before any new mandate comes down? I define as at a high level summarize the pieces driving mandates for states in the Mid-Atlantic, and have a hypothetical scenario of what could happen from CMS federally. But I'd bring a number of states in the hypothetical for the federal level to kind of put some bookends on it. Okay, so it'll be somewhere in this range most likely. And then an update as well at the end if we have time. I'll go through some other updates. But the overall just this presentation and the driver meat of it is nursing industry before mandates, and then what would mandates do, right? So, okay, before going into some of this data, I know for like the accountants in this webinar, they may they know this calculation, whether they want to or not. But I just want to make sure we define what I'm talking about. I'm talking about hours per resident day. You take all the productive hours on the left-hand side of the slide here. You take all the productive hours, so the registered nurses, LPNs, CNAs, and nursing assistants, and what's provided already to provider-based journal. So for facilities out there that receive Medicare, they have to quarterly provide their productive staffing. It's called provider-based journal, and that goes into the 5-star calculation. And that same data, it should be productive, right? So you should exclude, well, you're supposed to exclude, I'm sure all clients I work with do, you exclude all the PTO, the sick, vacation, holiday, and education, right? You're not supposed to include non-productive time in that. It's just the productive time from direct care. And I'm taking the current calculation and what's provided provider-based journals as we go through this. And I'll speak to later on some opportunities, maybe where the CMS, first of all, the definitions for the accountants and attorneys haven't come out yet from CMS on staffing mandate, right? But it'd be interesting to see what support positions they layer into any, if they like increase the minimum level of staffing, are they going to add other positions in there that are more administrative than historically, right? So like something like scheduler or ADON, something like that, that's not providing the direct care, right? Are they going to include positions like that in it? But I'm taking how things are currently provided to CMS, current calculations. When I say hours per resident days, taking all those productive hours, right? And then you divide by resident days. And resident days are your average daily census, right? So if you have 100 beds and it's 70% occupancy, you'd have 70 average daily census. And then you take it by the days and the time period. So in my maths I'm going through, I'm annualizing on an annual impact for cost and staffing. just because that's a period everyone can relate to, right? But if you're looking at quarters or months, you would take the average daily census times 30 or 31 for the month, and then you multiply it times the 90 days or 91 days for the quarter, right? So when I say hours per day, thinking productive hours divided by resident days, and the point of that and why the regulatory environment focuses on academic professors write all these papers that who knows how much they operate that talk about hours per resident day. The point of it, I think, is that they are trying to say, okay, well, if you have so many nurses, direct care, here's how many hours within the actual resident day that resident is receiving care from nurses, right? That's the theory of it. So if you have 3 hours per resident day or 3.5 hours per resident day, that's supposed to mean that, that resident has his direct care employees and caretakers, they're providing 3 hours per actual day, right? So that's, and this is the math behind it, that's the theory behind it. So before we get to kind of applying the mandates and defining them in these scenarios, the industry before considering those, I mean, we already had inflation trends, the PHE funding, the provider relief funds from CARES Act, they're drying up, going away. Now it's folks who haven't yet are looking at what they can do for employee retention credits, right? But there aren't any more great federal grants out there. And then you get the PDPM budget neutrality. So that was where PDPM is from, when they changed Medicare away from RUGs scores on it, they looked at PDPM acuity, and it was supposed to be net neutral, but then, as you looked at care and how you documented care, as facilities did, actual reimbursement increased 4% for Medicare, and they were the government, CMS put it together. They thought it'd be net neutral, and per their math, right, per their assumptions, but it wasn't. So reimbursement 4%. So they said, well, we need to bring it back down, lower it 4%, right? So that's why it's, when you look at the reimbursement changes that were effective like October 1, next October 1, they apply inflation and they lower it to get this net neutrality. That's what it means. When you see that PDPM budget neutrality, they're lowering what they would have by inflation. They're lower they lowered it October 1, 2%. They're going to lower it next year. Their plan is another 2% to get back to what they thought was neutrality. All right. So it's like falling reimbursement and higher inflation. So that's nice. Plus staffing mandates. So then you look at national trends. So this is, I'm just taking a step of look at nationally within nursing. I have some Pennsylvania data here later on. This is pulled from cost report data. So it's a little bit dated because, the 21 cost reports, they were just filed in May of 22, right? So the data is just updated. So there's 22 cost reports. It's only even a June 30 year end cost report for 22 wouldn't be in a database right now, publicly accessible. So this is national data. You see occupancy decrease. So that's not news to folks. But I thought what's interesting about the slide and why I included it was that the excluding PHE funding. So if you took away the federal grants, all those CARES Act funds, you took away the PPP loans and the PRF, Provider Relief Fund grants that folks receive for lost revenue and are capable of taking from employees. If you took that away, nursing would lose money, right? This is nationally 20 and 21. So before you're looking at Pennsylvania, we're already losing money, and their staffing mandates coming down, right? I don't think you need an accountant to figure things out. So you're already losing money without grants, and grants have dried up. Let's get some data here on paramedics and hours per day. But then, it's CLAs, we look back, we took the cost reports and we said, okay, well, what if we get occupancy back up, right? So if we try to forecast the rest of 22, how it may end with the negative assumptions, okay, well, let's say there's no neutrality adjustments, but then we still have the same inflation of wages and supplies and drugs as before. Well, then we're still losing money. So even occupancy recovers up to 81%, and folks are still going to lose money, and this is driven by the cost inflation without increased reimbursement. Labor, during the epidemic or during the pandemic, we lost 238,000 of employees looking at the positions. Then we have some staffing data. Now, this is coming from what's filed with PBJ. So you can see on a national level, we're kind of stabilizing from hours per resident day. So the same calculation slide I showed before, we're stabilizing about 3.6 hours per resident day. There's definitely a trend there, since Q3 of 21 for staffing. So, this is pulling data nationally is when I got Pennsylvania here a little bit later. Hourly wages, this isn't news to folks, but here's objective data pulled from cost reports, right, for any of your internal discussions that the cost inflation, average hourly wage, increased 8% in 21. And then it was driven by aids, right? So, I mean, as we talked about before, operators know aids are driving a lot of the calls right now, and that's the biggest need. But here's objective data on what's flowing through, what's submitted on cost reports for Medicare reimbursement, right? So you can see the average wage is increasing. Contracted nursing cost per hour increase as well. On that, I don't think that's news to folks. We have some data in here on the use the nursing pool. So we took from cost reports all the total hours from employees to nursing pool. When I say nursing pool, I mean like agency or contractors, right? Where you don't have enough employees. If you see you took all the providers and what percentage of them, well, back in 17, only a third of providers used nursing pool hours, right? But now we're at 2/3. So quite a jump there from 1/3 pre-COVID to now 2/3 of folks are using contract hours. And for those that don't know, agency pool contract hours, they're 1.5 to 2 times the cost per hour as an employee, right? So that's going to hurt margins clearly. And then nursing pool utilization, when you look at the total hours of the contractors, right? Because they have to file, when you file for your 5-star rating from Medicare, you have to provide quarterly your direct care hours, and you separate those between contract and employee, right? So we can pull this data, and Medicare receives this data, CMS receives this data of nursing pool hours, percent of total nursing hours, including employees. So you can see this jump up. Right now, I know like 5.5% doesn't sound like that much, but we're double where we were 2020. This is total nursing hours. For those in 75th percentile, which really means the bottom quarter for this math, bottom quarter from a margin perspective, they're up to 14% of their total hours were nursing pool, right? And before pre-COVID, it was 6%. So clearly that's affecting margins. So then a number of providers will say, okay, well, maybe there's some national stuff and we're high quality and we get 5 out of 5 stars and we did great on our survey. Well, even then, we go back to 21 and we pulled the data and said, okay, well, here was their margins. It was 2.8%, which is very consistent from 2-star to 5-star, really 2.8%. But once you took out the PHE funding or the provider relief funds, CARES Act monies, everyone was losing money. Even the 5-star communities, once you remove that, were losing money during 21. So that means without the federal grants, you'd have lost money pretty much, no matter how high quality. And then we have data for occupancy. Clearly those that are 5-star, there's a trend there, a data point there that they have higher occupancy in 21. But between the 2 and 4, there's really not a trend. It's kind of consistent. They're all in the 73, 72% range occupancy between 2 to 4. So I don't know, I thought that was kind of interesting as well. It wasn't like a nice gradient line up to the right. All right, so then we get on the national trends, look at Pennsylvania. We also pulled data the same time period. So within COVID, there's weekly occupancy filings. I don't know how long it's going to continue. I don't know if that's going to have to stop once the White House ends the emergency on COVID. But for now, if there's any benefit from COVID, it's more data is being supplied out there. And then you have weekly occupancy. So you can pull by facility or by county as well. And within the state, you can pull by state, you can pull occupancies. Pennsylvania is trending higher than national. So within Pennsylvania, it is stabilized around 80%. All right, so we're not at pre-COVID levels, 89%, but it's stabilized around 80%. Right, so you can see a slight increase, I guess, over towards the most recent week of beginning of October that was available, but it's stabilized, I guess. So not quite pre-COVID levels, but it's stabilized. And if you're below, if you're still hovering in the 60s to 70%, I think it may be worth you evaluating, why that's happening. And is it market driven? Is it because units available, or maybe it's because you can't get the workforce, right? And you have a commitment to your current residents of how they should be cared for, and you're purposely lowering occupancy. That could be it. I mean, it could be. I've heard that, and I've seen that too from a provider. So I think that's a reason. But I think if you want to be back to more normal occupancies, or I don't like the word new normal, if you want to be back to where occupancies are within your state, I think 80% is a very reasonable goal considering that's where it's stabilizing. I did include in here data point from, we pulled the PBJ filings, the number of beds that are available from the 681 Pennsylvania facilities. I thought it's interesting to include as well that each 1% shift in occupancy represents about 866 average daily census. So that's, 866 seniors that are in facilities each day, right? Each 1% shift of occupancy is that calculation. And then if you were to assume that each resident stays approximately 90 days, which I know for Medicaid long-term care is much longer than 90 days, but to get an average between the short-term rehab and Medicaid, if each one stays 90 days, each 1% shift occupancy affects approximately 3,500 seniors. So that was interesting to know. Also having here for your information, the occupancy. I just pulled, this is something, my presentation was shared this morning with Kimberly, so she has a copy of it. And I just put in here though the occupancy as of October 2nd by county, and just ranked highest to lowest on the left to right. So I don't know, I was deciding I should do by alphabetical or highest to lowest, but I think highest to lowest is interesting, so you kind of reinforces where your county is. And you have data, it's a data point here, right? So you can find your facilities and look at your county and see where they compare. Clearly Union County is really high, 94%, that's awesome. And Forest and Huntington. So then staffing per resident day. So this is again the metric of, before when we looked at nationally, I'm gonna go back real quick. Yeah, here's a national of all facilities in America. They're flatlining around 3.6 hours per resident day, right? So it's a consistent trend there. We look at Pennsylvania, it's very consistent with national trends. So, I think it's an objective point. People may say, oh, well, Pennsylvania should be higher staffed than other states. Maybe after these mandates come down from the state that I'll get to say Pennsylvania, may increase, but you're very consistent nationally. From the positions, it's 3.6. So I think it's another data point as well that, if you look at your facility and how they operate, 3.6 is a very reasonable goal, considering that's the median for Pennsylvania as well, right? Okay, so this is, now we're getting to more things only an accountant would love, but this is where I took the Pennsylvania facilities and have breakouts here. I'm not going to go through all these slides due to our time here together. It's a little limited. But I got all the facilities in Pennsylvania, and they have breakouts by size, and some more data later on regions within Pennsylvania. So within the facilities, 681 total Pennsylvania, all this data is from the last provider-based journal submissions are available. So the same data is provided to CMS for your 5-star rating is what's going into this data, okay? So we have on average facilities within Pennsylvania, the average size, bed size, 127 beds. The median point, which is the middle blue line, is 120. Then you get a 25th percentile, 76, and then the 10th percentile is 50. And then the 75th percentile is 150, and the 90th is 200, okay? So, but that same approach of 10th percentile, 25th, median, average, 75th, 90th is the same on all these box plot graphs here, okay? And I did this in this format so you can kind of compare as you look at different sizes of communities, because I have breakouts by sizes. Okay, so in occupancy, the median 79%, right? This was as of the Q2 of 22 for that whole quarter, right? Which is similar to when we're looking at weekly occupancy trends. We're coming up a little bit, we're above that now as of early October, right? But so within that data, everyone 79% is the median, as the midpoint. The average was 76%, and the average was below median here because, well, there's some communities that are way below, right? Way below that. Some are at 57%. I do want to point out that the bed counts and the beds available, right, in this calculation, because it's beds occupied divided by beds available. It's the numerator and denominator in it. That it's based on what's registered and licensed with CMS of beds available, right? So there's some facilities that are way below this occupancy level, but maybe they purposely and practically decide to shut down a wing and not operate it currently, right? Not make it available. So anyways, that's 39%, average is 76. Okay, so on the far right, this is where we get to the mandate. It's very important for when we get to the mandates discussion, because now, I'm not talking about what mandates will do. Right now, I'm just talking about where things are, right? So based on objective data, here's where things are. Okay, so on all the facilities in Pennsylvania, the midpoint was 3.45. The average is 3.7. Well, it's high. The average is higher than the median because some facilities are staffed really high, right? In their direct care hours per resident day. And maybe they have more Medicare or whatever in their payer mix, but some were really high. but the median is 3.45. And then when you drill down by position of a breakout for aides, you know, around 2, right, 1.95, average 2.04. So I think a goal could be aides around 2 hours per resident day, right, between the median and average. That could be a goal. Or if you're above it, you know, hopefully you're getting a lot more Medicare, right, or private pay where the market is recognizing and paying a premium for your quality of care. And if you're not, well, I think it'd be worth looking at, right, if you're above these medians and averages. License, I have a breakout for license, and partly that's because when regulators wrote these mandates, they speak to license, right? The New York mandate has a minimum number of licensed nurses. So a breakout for license, when typically I just break out aides, LPNs, and RNs, but breakout for license to show it. LPNs, you know, 0.86 median to 0.88 average, right here in the midpoint, and then RNs, you know, 0.7 to 0.8, right? So that's kind of where Pennsylvania's fallen out. Then I break out. So I broke out, I tried to find, you know, quartiles within Pennsylvania, number of beds to do breakouts for facilities, because obviously there's some that are much larger than the 120 and some that are much smaller. So for those who are less than 80 beds, you know, here's the same data. I break out for 80 beds, for those that are 80 to 120 beds, for those that are 120 to 160, and then greater than 160, right? So breakouts for all those. And when I look at Pennsylvania compared to other states I work with, I mean, it is smaller in the bed count than, you know, there's a good number of less than 80 bed facilities. I mean, 180, right? So over a quarter, over 20 or 25%. And the average, once you peel out those are less than 80 beds, you know, the average of them is 53. So a good number of smaller facilities. And then occupancies are stronger, right? Less beds, so occupancy is stronger, but staffing is really high. I mean, if you look at the staffing for the less than 80 beds, you know, they're at 4 hours per resident day, 4.25. Well, then the median for all the facilities is 3.45. So obviously there are economies of staffing that are tough there, right? In smaller facilities, you have to have a minimum number of licensed positions, and plus the layout could be tough for efficient staffing. When you get to those that are you know, 80 to 120 beds, you know, I'd say that the staffing's very in line with the average. Occupancy very in line, so very consistent. The 120, 160, again, pretty consistent with the overall Pennsylvania trends. And the greater 160, they're the most efficient. So it's nothing too surprising there. I mean, sometimes, you know, we take a step back, it's probably not that surprising, right? But I've seen some states where actually the most efficient staffing is like in this 120 to 160 frame, and some of the larger ones lose some of their efficiencies. But in Pennsylvania, you know, the larger facilities are the most efficient. And it's mainly driven by, as you look at it, driven by the aides, right, and how they could be more efficient with their aid staffing. Okay, so I have some data in here for the Pennsylvania market as well, and within Pennsylvania, Philadelphia metro broken out. We didn't have this just came from some data regularly available that CLA produced from NIC data. We didn't have Pittsburgh region, the West region, or Central PA, so I'm not gonna spend a lot of time on this to respect of everybody, but I'm gonna point out some trends that I've noticed in Pennsylvania. And the overall trend from this is that, and again, this is pulled from NIC data, right? This is valuable data. This isn't like some survey. That within Metro Philly, which I think is pertinent to Pennsylvania overall, the assisted living occupancies is below the primary markets is the top 20 metro areas in the United States, right? So, but for Philadelphia, Metro Philly, the occupancy is below that, right? So assisted living, personal care, it's below. But then also, we're still building assisted living and personal care. And that's definitely a trend. And that's something I see in Metro Philly to, you know, I'm in Baltimore. I see it through Metro DC, not so much in Maryland, but I see it around Metro DC. So, you know, in the areas around the north side and south side of DC itself and Philadelphia. I think it's in these higher income areas that have positive demographics of just the trends of seniors with money, right, with the means to pay the high monthly fees. There's definitely a trend of for-profits building more assisted living that are really nice. I'm not just saying that to use a fluff term. I mean, like they have like spas and a entertainment center and theater room and bar dining, casual dining, right? Plus the formal sit-down dining. that would, I would think, be more in like a typical ILAL, but it's pure licensed assisted living. And they're doing it to pursue, the couples, if one spouse has more needs. And then also they're providing all types of levels of care in there. I think it's a way for some of these for-profits that don't want to deal with the regulations of nursing, with the mandates aren't going to help with the regulations of nursing. And then also provide, nice amenities and common areas for those are more independent, right, that may go there. And they put like the lowest room and board fee they can find, and then they have add-on charges for acuity and healthcare services and home health and things like that. So it's definitely a trend in Metro Philly and Metro DC. Okay, so now I'm shifting to the mandates. All right, so we already talked about the industry itself. Without the grants, federal grants would have lost money, right, past 2 years. And then staffing mandates are coming down. You have them in Pennsylvania, and then also at the federal level. So current requirement was 2.7 direct care hours per resident day. So when it's same calculation as mentioned before, the 21 proposal, there was the bear of 4.1 direct care hours per resident day. That's what was being talked about in 21. In summer 22, there was news that it won't be 4.7, it'll be 2.87. And then very recently, they came out with saying 2.87 for July, and then 3.2 for effective July 2024. So they're ramping it up a little bit. I mean, I don't know, 2.7 isn't that bad, right? It's easy for me to say, but I've been a CFO before. I've been a CFO of a multi-site. Okay, so I'm not just some consultant that's saying something's not that bad. All right, but 2.87. And compared to other things we're hearing is relatively not as bad, right? And then 3.2 is getting tougher to meet. And then they have the 70% of expenditures to patient care, which is very similar to New York, have to pertain to that. So in my math here, I just focused on the staffing mandate direct care hours per resident day. And partly the reason of that is that I just know from work providers, you may be able to structure relationships and outsource services and those types of things that get into 70% expenditures, that those assumptions can really vary, the assumptions on that can really vary how much margin comes back to owners. All right, so Pennsylvania's going 2.87 to 3.2. New York, which our board of New York are well aware, but it's hit the high notes here that it's supposed to be effective January 1. It was suspended on March 31, became effective April 1. Based on the same provider-based journal submissions you make for CMS. And they have 3.5 hours per resident day. And then of that, 2.2 is to be provided by aides position, and no less than 1.1 of the license. So that's the combined LP and RN. So they have a 3.5 minimum, and then also they have minimums for the aide and the licensed positions. Yeah, I mean, it's a big jump. And when we did the analysis, and I worked on that for New York, it was like 63% of New York facilities before, because we did that analysis back in March, before they enforced it in April. There's 63% that weren't even meeting 3.5. So, I mean, you don't even need, obviously, you need an accountant to tell you it's going to be expensive. All right, so that was 3.5. New York, that's pretty strong. I mean, it's very strong, 3.5 minimum. Okay, DC is one of the strongest in the country. So they have 4.1 right now. And I think they're one of the ones that are creating all this noise. I mean, and that's physically in DC, okay? And there aren't that many nursing providers in DC. I'm involved in DC as well. I'm actually on the board of a nonprofit nursing assisted living facility. There's a couple locations in DC, and there really aren't that many. And I mean, less than 20 nursing facilities, right? It's 4.1. And then also during the height of COVID, I know really wasn't being enforced at 4.1. So it's a higher regulation. And then during the emergency periods, they weren't enforcing it. But anyways, that's what they have the minimum threshold. And then 4.1 hours per resident day. And then of that 0.6 is provided by an RN, right? So the 0.6 hours per RN isn't bad. We already saw in the data that, I mean, number of providers are already doing that, right? Here's the 120 to 160, the median's 0.6, right? So that's nothing, right? That RN. It's the 4.1, right? That's being made up mainly by aides. It's tough to hire aides anyways. And then plus, especially if you're in areas that are really rural or areas that are, in a downtown or very urban expensive location, So majority of providers, it's tough to hire positions, right? Okay, so I've got New York in here as well, and then the DC, and then right now for CMS, where are they going? What do we know? Well, we know that Abt Associates through September, October. I'm not sure in November right now they still are, but I know for sure in October they still were visiting facilities because I talked to association in DC, and they said they're actively 2-1 at that point. And they're supposedly listening to providers, how they provide care, and looking at how they staff it. So I don't know if they're going to take that in, but that's what they're doing. The goal was to have a mandate in place by March of 23. And then if you Google 4.1 and CMS, you'll just see a lot of articles hit. And nothing is out there right now, right? Nothing says that it's going to be 4.1. They haven't said that. And then also, the accountant in me says, well, what position is going to be in there, right? The definitions are important, how they calculate it. But they haven't put that out yet. But it'll hopefully be out in spring of 23. But if you just Google CMS and 4.1, you'll see they mention 4.1 a lot, and they cite some professor and academic on that. Okay, so staffing mandates here. I was going to look at the clock to make sure I got about 12 minutes left. So I went through the calculations. We took PBJ filings. We took the cost assumptions, came from cost reports, right? So it came from whatever data is available in the database for cost per positions, wages and benefits, okay? So we took that. I did not make an assumption on inflation, which, as we all know, costs have gone up on inflation, but I didn't do that, right? I'm trying to, these calculations, we're trying to be conservative. And even if we get to a big number, fair enough as is, okay? So try to be conservative, not make inflation assumptions, just take actual objective data that people can trace to. Did not assume more nursing agency costs have to be included. So just assume whatever your current wages benefits are for those positions, that'll be the cost necessary to achieve it. I did not layer on more agency, right? I think it'd be very easy to do. We saw the trends, more folks are using agency or have to use agency. But I didn't do that, right? I'm trying to be conservative in our calculations. Also, did not consider increasing occupancy. I'm just taking current occupancy of what was filed, right, in the PBJ files, in the provider-based journal filings. I'm not saying we're going to get back to pre-COVID levels of occupancy. If you get back to pre-COVID levels of occupancy, you're going to need more staffing, and the cost will be even higher, right? So I'm just taking what was filed, what those costs were, and applying to it. I have some breakout for regions in the data. I just pulled up to break it, just to have some more breakouts, because obviously Metro Philadelphia costs are different than North Central Pennsylvania and South Central Pennsylvania. So I have some breakouts for data too. Okay, so if we look at Pennsylvania and just take the 2.87 that's going to be required, how many facilities were below that in most recent filings? Well, 30 were, about 4%, so not many, based on the 2.87, just grossing those costs up, being used as wages. A little bit of cost. So getting a 2.87 coming up doesn't seem like too much of a hurdle at this point. And you have estimated staffing necessary. I mean, you would have to hire more to get to that level. You have to hire 227 more employees. That's just taking the staffing hours necessary divided by 2,080 to get to that. So, yeah, I mean, more aides is tough, right? I mean, it's easy for me to say, but 200 more aides is tough to hire for those facilities. But only at 4% were on a cost basis. As you can see, it's my breakout by regions. And you can see the Southeast is the majority of the facilities, right, around Philadelphia. And then we have Southwest around Pittsburgh as well. But those that are mostly below are centered in the Southeast area right now for the cost. But I mean, it's $9.9 million, which is serious money for all those facilities. But for those that were below, it's going to be about 330 extra costs, right? So, anyways, 2.87 at least appears, well, not positive, achievable, especially if the state's giving some extra Medicaid. So then we look at, okay, well, 3.2. So we take the last filing with CMS for its staffing and just layer on top to get to 3.2. And I would point out that in all these calculations, I looked at, I filled it with the aid positions, right? So you can see in Matthew, like there's no, first we said, well, how many total facilities are below? And then to get to 3.2, I filled it with what's the cost to staff with aides. It's another conservative assumption in my mind. I didn't prorate it and say to get to like to get to 3.2, you have to take your same mix of RNs, LPNs, and aides to get up to that level. I just said, well, we're going to be efficient operators, and to get that level, we're going to staff it with aides, right? So that's another way to be conservative in these calculations. So to get to 3.2, 27% of facilities in Pennsylvania were below, and it's about $39-40 million. And for those that were below, it's going to average about $217,000 on an annual basis to get there. On the far right column, I have calls per resident day. I think it's interesting, just because if you're looking at Medicaid and how much Medicaid's going up, you can say, okay, well, I'm going to need to increase staffing. Well, here's our calls per day for those to get up to this level, the extra cost, right? So, and how much is Medicaid going up, right? So I think that's why I included that, just for when you're thinking about reimbursement and per diems. Here's extra calls per day. From a staffing standpoint, for those 27% that are below, it's going to need about 1.8 million staffing hours, 854 FTEs. All right, so that's serious staffing need, 850. And again, I'm staffing with aides, and you could need a different mix, or you could need more LPNs and RNs within that. But 854 positions for direct care will be needed to get to that. So pretty sizable, I'd say. And then within Southeast, 436 are going to be needed. So that's tough, right? So, okay, so then I said, because now we're getting to like hypothetical territory. You already have some guideposts for what Pennsylvania has said. We don't know the CMS final ruling. So now I'm delving into, okay, trying to put some bookends on it. Well, here's some other states in the region that influence DC. And what if we took their mandates and just layered it over top Pennsylvania? And what would it look like, right? So we're getting some really serious numbers. I mean, 9.9 million is serious, but now we're getting to, if you meet that. And in order to meet that, they'd have to spend $158 million of extra cost per facility. To add extra $451,000 per facility. And you have to hire a lot more license. And for this to be conservative, I didn't assume the license would be filled with RNs. Like RNs cost, close to double LPNs, some positions. It's like 45 bucks for RN an hour. So the RNs are going to be not filled. I've assumed it was filled with LPNs, right? So that's to be more conservative too, to get the license number, we're using LPNs, not RNs. And so for that, it's going to be serious costs. You look in the costs in Southeast around Philadelphia, this be $59-60 million of costs needed, and 116 facilities are below the mandate if New York were to be applied to Pennsylvania. So that's 3.5. That's not even the 4.1 that was being discussed last year in Pennsylvania. So then from a staffing standpoint, 3,300 aides would be needed, 50 LPNs, so about 3,360 total positions to be needed for direct care. All right, so that's serious numbers for what would be needed for resident care. I mean, you can't even hire enough quality providers as is, right? You can't hire enough as is. And then somehow we're going to hire 3,360, or have to pay for agencies. Within DC, so DC is starting to get really serious. So DC, if you take their 4.1 and 0.6 RN, hours per resident day, from their regulations, and apply it, 74% of current facilities in Pennsylvania would be below that. So taking what was actually filed and layering on DC's mandate, 74% would be below DC's mandate. And then the cost, $376 million. For those that are below, the average cost would be $749, $750. Then you get the per resident day of $19 per day. So at some point, it's like these numbers are, it just kind of gets nonsensical in my mind. Some of these costs, but it's taking current mandates and applying to it. And then from an estimated staffing standpoint, the number of positions would be 7,200 needed, direct care positions needed. I did want to point out something for DC. I know that in Pennsylvania there was some extra surplus Medicaid monies that would be given to facilities, but DC during the entirety of when COVID first hit in March of 20, DC took their, they did a retro payment, and once the CARES Act funds got announced, so those things, they took that and gave all DC facilities a 20% premium on their Medicaid. And they've been giving it since that time. And it's not going to run out until 3 months after the White House says the emergency has ended. So they're still getting that in essence. So I mean, it's one way that they are getting, they have these higher mandates, and achieving the mandates is that they have, and they are still getting a 20% premium on Medicaid. And I know within DC itself, some of them can actually, they can, I don't know, make money necessarily, but they can do okay on long-term care, better than on, during COVID, they're doing better on Medicaid long-term care from a margin basis than Medicare, right? Because short-term rehab dropped off and wasn't that much, and it's hard to get efficient and all those things. So they're doing better on Medicaid from margin standpoint. Okay, so then another hypothetical to get to just, and I'm not doing this to give me more numbers. Now I'm just saying, well, okay, let's say it's 4-1 as CMS has mentioned itself. I'm not saying that's what CMS has mentioned. Some articles, they've cited 4-1 as quality. So if you get to that 4-1 and you say, okay, well, what if we take kind of a similar mix to what was, how the current provider, the current mix of licensed to aides, right? So if you take that mix and apply it to get to that 4-1, what does that cost look like? Well, if you take the current mix of how Pennsylvania providers currently have their mix of aides, LPNs, and RNs, it was like 55% aides and 45% license. If you take that current mix, just apply it to get to 4-1, kind of what does that do? Well, now we're getting even more numbers, right? If you just increase all the direct care staff positions to get to the 4-1 based on current prorated mix of direct care nurses, now we're at 463,922,000 calls per facility to meet it. And yeah, 74%. So three-fourths of all providers in Pennsylvania are currently below it if that were applied today. So yeah, costs are getting bigger. And then staffing wise, 7,700 staffing. So then just as a summary here, for those that are below, if you were to take New York and apply it to Pennsylvania, it costs $450,000. For DC, $750,000. And then direct care FTEs needed, we're from 3,300 to 7,000. So I think these are kind of the book ranges in my mind. Just trying to take from other states in DC, like New York and DC, that influence national discussion. Kind of what could it be? I think it could easily be in these levels, where for those facilities to meet it could cost $750,000. So we're like $500,000 to 3/4 million to meet it for those that are below. And then staffing wise, you need anywhere from 3,300 to 7,200 direct care staff from somewhere, right? So I guess it's the overall takeaway from it. I got data sources in here as well. I mean, so from costs, there were, of all the data points, only 2 facilities didn't have costs for some reason in the CMS database. So for those, use these assumptions, but you can see the wages here was $47.50 RN, 34 LPN was, and then $22 an hour aide. And I also have in here listed just for your information, the wages, cost, and benefits for those positions. So yeah, so I mean, I think it's conservative, doesn't include current workforce inflation, and try to be conservative in applying positions. Got some regulatory updates in here as well. The only thing I'd point out, I mean, so this is it, got wage increases. I talked about net neutrality. But what I did want to point out was that, the 5-star, so we've got specifications as we shift to the 5 stars. You all know there was a presentation given by a coworker of mine, a webinar about 5 stars. I'm not getting the details of it, but it's interesting that we have some mentions of administrative duties in here. And I just want to point out, because I think it's interesting, the accountant in me is thinking, okay, well, if you increase to 4.1, they got to reevaluate the positions that are included in that calculation. Because if I take the current calculation provided to CMS to get to hours per resident day, you can see that the costs are so high, it's getting crazy, right? I mean, so I think there may be opportunities to look at reevaluate positions, what's included in it. And that'll be very interesting to me of how they define positions that are included in that calculation. That's what I wanted to point out. Okay, at this point, it is 10 till. You have a copy of this packet. Is there any questions or Q&A from the group?
I do see, if you pull up the chat icon, John, there are 2 questions presented to you on there.
Okay, let me see if I can do this. Okay, thank you. Yeah, well, hospitalists, I'm not sure if it will. I hope that, right, so mid-levels, there's a question about hospitalists, PAs, and nurse practitioners. So like mid-level providers be included in staffing. I mean, I think that's something that's going to be looked at. I mean, right now the calculations were currently based on what's provided to provider-based journals, because I've not seen the definitions from CMS yet. They haven't been issued. But in my mind, if you're going to get up to 4.1, I don't know how you wouldn't either change the staffing that's included and or have a 20% premium on Medicaid long term like DC is doing. And then the other question is there a plan to apply similar rules to hospitals that own? Yes. It's, I don't know about from the acute care regulatory standpoint, that's different from this discussion. But those nurse facilities that are owned by hospitals, right, and I audit a health system that owns the nurse facilities. Yeah, they're required to meet these. So the nurse facilities that are owned by hospitals and or if it's a it's a nonprofit hospital, right? If it has a control over the nurse facility is required to meet these mandates for sure. Now the hospital is in the acute care setting, they have their own regulations they have to meet. But for the post-acute and the nurse facility, yes, they have to meet these standards. So to answer the question, any more questions or thoughts or?
Taking a look, and I don't see any additional questions in the Q&A channel. And honestly, if anyone has, looks like there's one more question that came up in the chat. Do you see that, John?
Okay. Yeah, well, swing bed units and hospitals need to meet this. I'm not quite sure the swing beds. You mean some behavioral health where they can shift to it? I mean, any of the beds that are providing nursing care, skilled nursing care. So if you have some of the TCU beds, behavioral health has its own reimbursement regulation to meet. But those that are attached to the hospital that may provide the rehab, right, to the mother or father that got a hip transplant, right? They have to meet these regulations. If it's a licensed skilled nursing facility, yes, they'll have to meet that. But if they're staying within the hospital acute setting, inpatient, no, they have their own regulations to meet. I the last time I was presentation for a different state, and some folks, I had a question about what's going to happen to nursing, what are folks doing? And I see a lot of transactions and pain right now of folks that own the nurse facilities that just can't make their margins work. And there's some that are selling, and the appraisals are coming in near real estate values. And it's not like they have great real estate. So and even once you get an appraisal, you have discussions with buyers, some folks aren't interested. So I think for folks that are interested, there are real deals that can be had. And it's not like 60-month no interest deals on a car. I mean, like folks are getting be able to acquire nurse facilities for prices that I haven't seen in recent history since like 07, 08. But it's just there are transactions going on. I think when folks are wired, so they think about, okay, well, someone's buying them. Why are they buying them? So I think those that are buying them are getting more towards outsourced services, especially when you see things like 70% expenditures have to be on residential care. The ways you can structure organization and provide dining, housekeeping, therapy through related parties in order to meet regulations, and you're still providing quality of care, right? Quality care to your residents. But folks just reevaluating how they're structured. And I think those that are buying them are trying to provide as many outsourced services to their facilities as possible and look at how their organization is structured.
Great.
Just going to add that to it. Yeah.
Well, thank you, John. I really appreciate the time that you took today. And if anyone does have any additional questions, please feel free to reach out via email to John or myself. And
yeah, great.
I think that's all we've got for today. Everyone enjoy the rest of your week.
Yeah, thank you all.
Thanks.
Bye.